Greetings and welcome to EHA Unplugged, the official podcast channel of the European Hematology Association, EHA.
So today I would like to welcome Dominik Wolf. He is from the Medical University of Innsbruck in Austria, and he's an expert in the immune system in MDS. So we're going to talk a little bit about targeting the immune system in MDS. So welcome, Dominik. It's nice that you could join us.
Hello, Kirsten.
So, I mean, we all know that transplantation works in MDS, right? And in essence, this is actually using the immune system to targeting MDS. So why do you think it works?
I think, so first of all, thank you for the invitation. Great to be here. And allo-transplantation is the prototype of immunotherapy for hematological diseases, which we all use since decades. And we all like it on one hand, but also we all dislike it on the other hand, because it saves a lot of lives, also for particularly high-risk MDS patients, but also it harms patients due to its toxicities in terms of non-relapse related toxicities, which is one of the major limitations. And there's a lot of advancement, but it's still a big problem in daily clinical practice, particularly GVHD management and all that stuff. I'm personally quite convinced, due to the long experience I have myself in transplantation of MDS patients and also AML patients, that it's indeed the long-term success of the technology indeed very much depends on the graft versus disease effect. Yeah. Because you can really nicely see also with the new methods of sensing relapses by molecular markers in patients after transplantation, when you then withdraw, for example, or reduce immunosuppression, or you even give donor lymphocytes as weapons fostering the graft versus leukemia effect, you can really often see that you can again go back to MRD negativity and induce long-term control of the disease. So in addition to just being a replacement therapy, the lymphocytic compartment, but also the NK compartment in the graft is definitely centrally involved in controlling the disease. But as I said, it's also the major limitation, because those cells can also do harm the recipients by inducing severe life-threatening or inducing a lot of morbidity burden in patients with acute and in particularly chronic GVHD. And interestingly also there's a lot of large big data, big file analysis from EBMT showing that you have a nice correlation of chronic GVHD and disease control. So you can't definitely spread those two, the one which is the therapeutic effect, meaning graft versus leukemia, and the one which is the, let's say, side effect, the graft versus host disease. It's somehow also linked, and I think it's still very important. We need this kind of therapy. I just came back from my round here. We have a young lady, same age, young, same age I have, not very young, middle aged. But having high risk MDS, and it's clear we have to go for donor search and go for transplantation finally to cure the disease, because still we don't have alternatives by using the immune system, for example, CAR T cells or other immunotherapies being a curative alternative for this patient population.
But I also think, this brings me to a little bit, back to earlier stages of MDS, where we know a lot of things are happening in the immune system. Why do you think, what do you think would be good targets, or what have shown to be good targets, and why are they not good enough? Can you comment a little bit on that?
Yeah, for me, the low risk MDS patients are a beautiful prototype of how the myeloid compartment induces inflammatory circuits, which is very important for the microenvironment in the bone marrow, meaning also the differentiation capacity of cells, but which can also induce in patients. All of you take care of MDS patients, and these patients which have inflammatory symptoms in addition to their MDS. Yeah. And some patients do not have any signs of inflammatory side effects, and others can have really severe hyperinflammatory syndromes. I'm not talking about VEXAS, which is a very specific subtype of a very defined mutation. I'm talking about really the classical MDS, having the morphological MDS, having also the mutational pattern, and these patients having inflammatory symptoms. And I think here we are currently learning more and more how genetics in the myeloid compartment imprint innate immune signaling, which finally leads to hyperinflammation, to production of, for example, IL-1 and IL-18, HMGB1 as a final readout of activation of the NAD3 inflammasome. Or we can also see activation of intracellular protein complexes, which are lowering the threshold of the TLR activation signals. And there are many TLRs out there which are usually recognizing danger signals, such as, for example, LPS from gram-negative bugs. And if you have mutations which affect these intracellular adapter complexes, which make signaling more likely when the cells are exposed, for example, to TLR activating signals by LPS, or there can also be other pro-inflammatory stimuli which activate the cells, you finally get hyperinflammation, which is where you can then see in patients neutrophilic dermatosis, fever, requiring steroids, arthritis, and all this stuff which we can see in clinics. And there are many studies out there trying to, from understanding the basic biology of what's going on in the cells, trying to transfer this to clinical concepts. One concept is trying in low-risk MDS to inhibit the NAD3-IL1 axis by canakinumab, for example. Yeah. Also, there are, I have been for 7 years at Bonn University, and there's one of the leading NAD3 researchers, Eike Latz, and we are collaborating a lot. And Eike has developed, for example, NAD3 inhibitors, developed in a spin-off, now taken over by a large pharma company.
So this is not in clinical trials yet, or is
it's just going into phase 1, but just showing you that NAD3 inhibition is, in addition, is more upstream to inhibiting IL-1. So this could be for the future, and these are the concepts trying to interfere with the NAD3 IL-1 caspase-1 IL-1 axis. Also, when you inhibit NAD3, you could be more efficient, or this could be a more efficient approach to inhibit induction of pyroptosis, which very much correlates to the differentiation defects in low-risk MDS, and which is mainly mediated by NAD3 induced activation of caspase-1.
And how do you see, because I think, there's the inflammation in the microenvironment, and then there's the inflammation in the myeloid cells in the clone. Yeah. So how do you see this interaction? Is the one dependent on the other, or
I think
are you inhibiting both the microenvironment and the clone? Or
I think we need to target both. It's a very good point you mentioned, because it's always like a chimera in the bone marrow. You have the diseased clonal cells and you have the non-diseased cells. And I think we can learn a lot from the story of MPNs, because at the beginning we thought, okay, it's the JAK2 mutant cells where we have to inhibit JAK2, and finally, particularly on a beautiful work from Ross Levine, we have learned that inhibition of JAK2 in the non-clonal compartment is very much involved in also affecting the clonal expansion. So it's, those cells always interact. There's the clonal cell, which has a genetic event which produces cytokine, and the other one responds to this also to the danger patterns in the microenvironment in the bone marrow, and they all it's like a folie à deux. So it's the non-clonal and clonal compartment. Probably we have to target them, both of them, but we are not there that we understand the mechanisms in that detail. And I think also based on the development of single cell technologies, for example, we are currently establishing a technology. We are doing a lot of single cell sequencing work, and we develop transcriptomic sequencing, but we need to annotate when we have a single transcriptome, the whole transcriptome of a single cell. I need to know the genetic background of this cell, and particularly in hematology, where you have different clones having one mutation, one plus the other mutation, and cells which are non-mutated, normal hematopoietic cells. We need to understand which pathways are really induced there to really more or develop more targeted approaches on the basis of anti-inflammatory treatment. But I think NAD3-IL1 is one possibility, which is very interesting in low-risk MDS, where the differentiation problem, the cytopenia, is the main problem.
Yeah.
Another development is targeting the MyD88 complex, where IRACs are essential in the signaling complex.
And that's the one we know from the lymphoid diseases, right?
Yes, exactly. That's the one we know from lymphoma and from Waldenström disease. It's MyD88 mutations, but here we have a different kind. It's not the classical MyD88 mutated activation of the MyD88 complex. It's rather based on proteins which are part of the complex. And IRACs play an essential role in the normal MyD88 induced TLR signaling transduction into the cell, leading to the output of producing cytokines. For example, normal cell responds to LPS in a sepsis or gram-negative and bacteria exposure. And here we have, based on spliceosome mutations, IRAC can be differentially spliced. And then we have an overabundance of the long form of IRAC4. And this long form of IRAC4 leads to a hyperactivation of this complex. And these IRAC inhibitors are clinically tested. There is some data out there. It seems promising, but it's very early. And the basic idea is also to trying to interfere with this inflammatory signaling circuit in MDS.
And do you think this is even part of the whole? The way that MDS arises, when you go from CHIP or sequence to MDS. I mean, is this driven by inflammation, you think, or is it what do you? And is it association to different types of mutation also, or how do you?
It's a very good question. I mean, I think everybody, or let's say it's accepted that chronic inflammation leads to ROS production and chronic local stress of hematopoietic cells. And I could envision that chronic inflammation also induces the clonal development or clonal expansion of chip clones, then leading by somehow having hyperproliferative features, leading to secondary genetic events, really finally ending up in a dysplasia coming from normal hematopoietic output from clonal hematopoiesis, perhaps going over CCAS, then really going to dysplasia, which maybe at least in some patients very much depend on induction of pyroptosis by activation of the IL-1 pathway. But I'm not so sure whether, because CHIP is so frequent, and I'm not so sure whether this is the only, whether the inflammation in the CHIP clone itself is the only driving force. I think it could be that there are other inflammatory external microenvironmental driven forces. And I think there's a beautiful model coming from lung cancer where, Charlie Swanton has just recently published this air pollutant paper where they show that in the lung, we have, let's say the lung chip is the GFR mutation in the epithelial cells. But then you have the microparticle dust exposure, which induces NALP3 inflammasome in myeloid cells, particularly macrophages. And this inflammatory stress by the air pollutants induces then the transformation, and then the KRAS mutation comes on top, and then you see the transformation. And they have really shown beautifully that EGFR mutated lung cancer is directly correlating to the microparticle exposure. When you look at the big cities in Asia, and you compare this to probably let's say one of our side values here, it's really a highly correlated observation. And I think it could be that we have the same model here. We have a spontaneous age-related sensitivity of hematopoietic cells to get a chip lesion, and then we have external factors. There was a recent paper showing that, for example, adipositas is driving clonal expansion of chip clones in a nice murine model. So I think it's a very complex mixture, but for me it's hot topic because So
do you think we can prevent MDS progression?
Yeah, perhaps we can prevent MDS progression by being more efficiently having anti-clonal therapies. I think we have to reduce the clonal size and we have to reduce inflammation, anti-inflammatory and anti-clonal. And it's a bit like when you go to MPN, it's a completely different field, but conceptually, you can induce anti-clonal therapy with interferon. It's a pro-inflammatory cytokine, and you can be very perfectly anti-inflammatory with JAK inhibitors. But we don't have this very, very strong anti-clonal drugs in low-risk MDS because we can't, interferon is not a good idea in this setting. But conceptually, I think that would be interesting.
So is this because we actually don't have anything that reduces the clone in low-risk MDS?
Yes, we could perhaps reduce the clone by ATSA, but we don't use it in this setting. We will rather try to reinforce blood production by growth factors, or luspatercept, which is also some kind of,
Actually, there was an interesting talk by Valeria Santini at EHA showing that imetelstat could actually reduce the clones. But I don't. That was sort of, for me, a completely new discovery, I think.
Definitely.
What about the adaptive immune system? Does that? I mean, people have been trying to target that in MDS. What do you think about that?
Very difficult. Data are not convincing. We don't have the right targets. We don't understand the targets. When it comes, for example, to checkpoint inhibitors, there are many trials, but the data is disappointing. The only checkpoint inhibitors which seems to be interesting, I mean, Neil Dever has published in the May issue of JCO, for example, the combination of magrolimab together with azacitidine in higher risk MDS patients. So I think the myeloid checkpoints seem to be more interesting. The TIM3 data are a bit disappointing. The first stimulus phase 2 is a bit disappointing, but let's see what's coming out then in the randomized phase 3. I think we have to dig deeper, and probably it's also due to the complexity of the disease. The all-comer studies with these kind of approaches are very likely not to be positive. So I think we need to understand the basic biology better to better pre-select patients, which are probably the ones which select, for example, from magrolimab or from TIM3 antibodies, or perhaps there are even some of them which may be sensitive to classical checkpoint inhibitors such as ipilimumab or nivo. But actually, in the studies so far, the signals are not very strong. The signals for magrolimab are strong. I mean, the CR rate is something between 35-40%. The overall response rate is good. The TP53 mutants seem to be very encouraging, and even if you then go to transplant, the data looks quite interesting. So I think it's early, but it's a very good and interesting approach.
Yeah, and that's probably one of the very few things we've seen working in TP53 mutant.
Definitely.
And of course, also if we go more to the experimental side, what about CAR-Ts in MDS AML? Do you think that will have a role, or
One problem is the target. Because
exactly.
It's a hematopoietic stem cell derived disease, so the targets are often shared with normal hematopoietic stem cells. I mean, we all know the paper from 2018 published in Cell in monkeys and in preclinical models that you can combine stem cell transplantation, taking out the 33 and transplant the stem cells without the target, together with the CAR T cells, targeting the target on the myeloid cells. But I think it's a very complex setting, and the appropriate targets are currently really lacking. There are early clinical trials of technologies trying not to use CAR T cells, which already have the single chain bound to the transmembrane domain, so that if you infuse the CAR T cell, that it goes directly to the targets on the myeloid cells, but also on the healthy cells. But that you use adapters. So you have a CAR T cell which is somehow cold, and you have, for example, a leucine zipper, and then you give a drug which on one hand side targets the myeloid target, and on the other hand side it binds to the cold CAR T cell, but you can compete with these small drugs when they induce toxicity, such as severe CRS, but also perhaps inducing aplasia. But I think addressing and identification of the most appropriate targets is one of the biggest problems. We have not only in myeloid diseases, also in T-cell lymphomas, for example, where everybody, is so hard to treat, so difficult, and no CAR T-cell therapy available. It's a pity, and I think we have to dig deeper there. There is early clinical trials on CAR T-cells, also in MDS patients, but it's definitely too early, and it's far from clinic, to be honest.
And isn't it also a problem that sort of MDS, I mean, if you have an advanced MDS, almost all the stem cells are part of the clone, right? So will there be residual stem cells if we target the mutated ones? I don't know, isn't that an issue also, that we almost need to have a transplantation on top? Or
Yeah. And then you can ask, I mean, what is then the net benefit of doing it when you anyhow have to go for a transplant?
Exactly. Yeah, then it's probably too complicated.
You don't have the possibility to have an autologous regrafting because you don't have healthy stem cells. I think that for me, in myeloid diseases, allo-transplantation will be in place for the next, let's say, at least for a decade.
Yeah.
I don't see the developments which can replace allo for high-risk MDS so far currently. I more see the anti-inflammatory potential in earlier lines of MDS and the hyperinflammatory patients. But in high-risk MDS patients, I see transplantation in place for the next at least 10 years.
So in the early phases, it's actually more preventing progression than
Definitely.
Yeah.
And there we have to understand. I mean, we just recently finished a project where we collected 100 patients, and we want to understand, because we know in lower risk MDS, fatigue is a strong driver of, is a prognostic factor. And why is that the case? What is fatigue really? I mean, also in long COVID, what is the fatigue? I mean, is it subtle chronic inflammation? And I think in MDS, we should really trying to dissect and bring together fatigue, which is not a result of having a low hemoglobin. It's a result of hyperinflammation probably, and we have to understand which mutations do induce which pattern of cytokines, which then induces fatigue, which may also drive the more quick transformation to overt AML then, or which then is a potentially life-threatening situation.
I think that's a very interesting endpoint, because this is also one that really means a lot for the patients, right? So do you think this inflammation is actually in the central nervous system, or how do you envision the combination of inflammation and fatigue?
It could be that it's a very good point that it's an inflammation which also affects the CNS and thereby induces the mood symptoms. Yeah. But the problem is that we do not know, or we do know nothing about the clonal composition of for example, the myeloid cells in the brain. Whether that takes, there are some patients where you have quite a large proportion of hyperinflammatory myeloid cells in the CNS, or whether it's a cytokine mediated phenomenon, that there are specific cytokines which do go to the CNS and induce the mood symptoms and the fatigue. It's an open question, but clinically it's highly relevant.
Wow, I think we came really very well around the whole subject here. So I think thank you so much, Dominik, for enlightening us this complex of inflammation and MDS, which I think we can work on many years still. And I hope that sometimes this will lead to new treatments for MDS patients. So thank you very much.
Thank you, Kirsten. It was a very nice conversation. Thanks.